Welcome to this webinar of the International Menopause Society, which will be dealing on the topic of migraines. This is something that we all know. It is very important and will be addressed by two big professors and investigators. Firstly, I will introduce myself. I am the moderator. My name is Antonio Cano. I am professor of obstetrics and gynecology in Valencia, and I am a member of IMS, where I am co-chair of the Council of Affiliated Menopause Societies and also a member of the Educational Committee. We all know, as I was commenting, that migraines is something which is quite frequent. It is calculated that around 14% of people in the world suffer of chronic migraine, and women suffer it more often than men. There is a role for hormones, and this is something that will be adequately explained today by our speakers. This webinar has been supported by an unrestricted educational grant from Vecins Healthcare. Vecins Healthcare had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speaker's presentation. So let's move now to present our speakers today. We have, firstly, Professor Raffaele Ornello. He's a researcher in neurology at the University of L'Aquila in Italy. His research interests include the epidemiology of migraine, with a special reference to its vascular risk, the real-world investigation on the effectiveness of migraine-specific preventive treatments, and the epidemiology of stroke, with a special reference to intracerebral hemorrhage. For the second topic, we have Professor Rossella Nappi. Professor Nappi is full professor of obstetrics and gynecology, chief of the Research Centers for Reproductive Medicine and Gynecological Endocrinology Menopause Unit at the Institute of Research San Matteo Foundation and the University of Pavia, also in Italy. Her major interests are in the field of psychoneuroendocrinology of female reproductive and post-reproductive life, with a special focus on women's sexual health. So let's go to start our webinar. And for that, we firstly will start with Professor Raffaele Ornello. Please, Raffaele.
Okay, thank you, Professor Cano, for your kind presentation. And I am, as you told the audience, I am a researcher in neurology at the University of L'Aquila. I work with the group of Professor Simona Sacco, of whom on behalf of whom I would like to greet the audience. And we are a school with a long experience of the study of the association between migraine and vascular risk. I first would like to show you what Professor Cano just told you, and the fact that when we talk about migraine, we talk about women, because more than 3/4 of individuals with migraine are women, but especially disabling migraine is particularly frequent in women. And you can see that one in studies regarding migraine treatments, 5 out of 6 subjects are women. So it's a really female topic. It's relevant to study migraine and its vascular risk, because it's a concerning vascular risk, particularly for women. Not all strokes are the same, and not all migraines are the same. We should distinguish between migraine with aura and migraine without aura. Migraine with aura, the aura of migraine is a series of neurologic symptoms, such as visual symptoms, sensory symptoms that precede the pain. So migraine is not only pain, It's pain with associated neurologic symptoms. And this kind of migraine has a particular association with the ischemic stroke. But not only stroke is not the only association with migraine, vascular association, because our group found that with the meta-analysis that even myocardial infarction and ischemic heart disease is a particular association, vascular association of migraine. So we should say that migraine is associated with vascular diseases, not only cerebrovascular diseases, but vascular diseases in general. And another important point to point out is that history of migraine or active migraine are not the same, because when women have active migraine, I'm here showing a study that was performed exclusively in women, so 100% women population. The ischemic stroke risk is heightened only in women with active migraine and not with a past history of migraine. So to be at risk of ischemic stroke, you should still have migraine attacks, and you are at increased risk of stroke if you have migraine with aura, so with associated neurologic symptoms. So to conclude on this first part of the presentation, migraine is a well-established risk factor for ischemic stroke, but also for cardiac ischemic disease. The vascular risk is better proved for migraine with aura, while it is less evident for migraine without aura, which represents the majority of migraine, fortunately. And the risk is more evident in young subjects with an active migraine and less evident in older subjects with a past migraine history. So there is a huge body of literature about the possible mechanisms of association between migraine and vascular diseases. An important point, a peculiar point, is that the lower is the amount of traditional vascular risk factors, and the highest is the risk of ischemic stroke associated with migraine. So we can say that migraine has its own kind of vascular risk that is independent from hypertension, diabetes, and other traditional vascular risk factors. That was proven in many epidemiologic studies. I am here showing one of the largest ones, that was the Oxford Vascular Study. There is kind of a genetic association between migraine and vascular events and vascular risk, because you know, migraine can be interpreted as a neurovascular disease, so in which there is a vascular component together with a neurological component. And genetic studies, the genetic association studies, confirm this association, because if we see the genes associated with migraine, here you can see an important genome-wide association study. We see that many genes associated with vascular functions have peculiar associations with migraine. So what's the point of the association between cerebrovascular disease and migraine? And the point is probably in this phenomenon. This is cortical spreading depression. The spreading depolarization of neurons in the cortex is associated with the migraine aura, but also with migraine pain, and it's a spreading depression in the electrical activity in the cortex that is associated with a wave of marked vasodilation and increased blood flow that is followed by a lasting oligemia. So it confers a peculiar vulnerability of the brain with migraine, of subjects with migraine, to a decrease in blood flow. So when we decrease the blood flow in the presence of those mechanisms that lead to stroke, the brain of subjects with migraine could be particularly associated with a spreading of these phenomenon of oligemia, of reduction of blood flow. So the brain of subjects with migraine might be more vulnerable to the negative effects of this spreading oligemia that can lead to ischemic stroke. And this phenomenon could also explain what is found in subjects with migraine. Many of them have these white matter abnormalities that are not associated with ischemia or other phenomenon, but can be associated with oligemia, with this particular vulnerability of the brain tissue of subjects with migraine. Microemboli have also been involved in the pathogenesis of this particular vulnerability of the brain of subjects with migraine. There are many compelling animal studies that showed that the injection of microemboli into the cerebral circulation could generate microinfarcts, but in experimental animals. But the important thing of this kind of experiments is that together with micro ischemias of brain tissue, the injection of microemboli also produced the waves of depolarization. And these waves of depolarization have also been found in subjects with migraine with aura. So microembolism could be the link, occult microembolism that we cannot see with the naked eye, can be the mechanism linking the vascular vulnerability and the brain vulnerability of subjects with migraine, and especially migraine with aura. Another important mechanism that can mediate the association between ischemic stroke and migraine, and especially migraine with aura, is patent foramen ovale. Because patent foramen ovale is particularly frequent in migraine, and especially in subjects with migraine with the aura. We still do not know well this kind of association, so we cannot conclude that closing the patent foramen ovale can resolve migraine or can resolve migraine with aura. So there is still no indication for patent foramen ovale closure to cure migraines. And this is an important point to stress, because we still do not know which kind of subjects with migraine are susceptible to microembolism coming from the patent foramen ovale. But we still know that there is a clear association between the prevalence of patent foramen ovale and migraine with aura that can explain part of the association between migraine and ischemic stroke. I also would like to cite this important study performed in a limited number of subjects, in which there was an injection of microbubbles of air into the veins of this subject, which is a popularly performed diagnostic test for patent foramen ovale. And the authors found that the injection of microbubbles into subjects with migraine with aura and patent foramen ovale caused electrical alterations in the brains of these subjects. The important thing to note was that patent foramen ovale and the absence of migraine, so the injection of microbubbles across the patent foramen ovale in subjects that were not affected by migraine, did not cause any alterations. So you need to have both migraine with aura and patent foramen ovale to develop susceptibility to microemboli. Again, we should consider migraine as both a vascular and a neurological disease, and both components determine the increased risk of ischemic stroke. Funnily enough, the presence of migraine with aura was found as a risk factor for incidence atrial fibrillation. So another risk factor for stroke. We also have to say that migraine is per se associated with an increased risk for thrombophilic alterations. So even thrombophilia can be a mechanism explaining the heightened vascular risk of patients with migraine. What is the role of oral contraceptives in this association? We should note that not all oral contraceptives are the same, because there are some compounds, especially estroprogestin pills, intermittent estroprogestin pills, that are associated with the maximum increase in the risk not only of ischemic stroke but also of migraine. So they could be a confounder of the association and a component of the association. But there are also large studies. I am citing here the largest one performed in over 1 million women that found that the maximum of association with the risk of ischemic stroke was found in women with migraine with aura, again, that used combined hormonal contraceptions. So hormonal contraceptives containing both estrogen and progestin compounds. So this is the subgroup of women with the maximum vascular risk. We should note that progestogen-only contraceptives are not associated with a significantly increased risk of ischemic stroke. So this kind of this large body of literature was condensed in some ESC recommendations, according to which the presence of migraine with aura should be considered in the assessment of cardiovascular disease risk, especially in young women, I should say. And the avoidance of combined hormonal contraceptives may be considered in women with migraine with aura. The same recommendation was performed by a consensus of which the leads were Professor Sacco and Professor Nappi. And according to this consensus, there was a recommendation to avoid combined hormonal contraceptions in contraception in women with migraine with aura, while a cautious use of those kind of compounds could be considered in women with migraine without aura that do not have a so high a risk of vascular disease. So I would like to conclude with some key messages. There is a strong evidence of association between migraine and vascular risk, especially with migraine with aura and muscular risk, not only cerebrovascular, but also cardiovascular. The mechanisms of association between migraine and stroke are complex, and they are not linked to conventional vascular risk factors. So migraine has a peculiar kind of increasing vascular risk through non-conventional mechanisms, such as occult microembolisms or thrombophilia, or the presence of patent foramen ovale. Women with migraine should strictly follow lifestyle and preventive recommendations to control vascular risk factors. As migraine is genetically associated with an increased vascular risk, we should still be cautious about women with migraine and advise them to enjoy their life without conventional vascular risk factors, especially the avoidable ones such as smoking, sedentary lifestyle. So we should advise them to enjoy an active and healthy lifestyle to prevent their vascular risk and even their migraines. Thank you for your attention.
Thank you, Professor Ornello. It was a very nice. I forgot to mention that questions will be addressed at the end of the webinar, whenever Professor Nappi has finished her talk. So I'm sure there are already many questions to raise because it is a very interesting and also quite unknown topic for many of us gynecologists who are clinicians. Okay, so now let's move to the second talk. Our second speaker is Professor Nappi. I already presented her as the leader of the Research Institute in Women's Health in the University of Pavia. You have also there some of the many indicators of the quality of Professor Nappi as a professor and investigator. She is board member of the International Society of Gynecological Endocrinology, also of the International Academy of Human Reproduction, and importantly is the president-elect of this society, the International Menopause Society. Even more, I may say that I'm a very good friend of her, and I am very happy to be so. So, Rossella, welcome. You may start whenever you like. We are just eager to listen to you.
Antonio, ciao Raffaele, and hello to everybody. Sorry for the small delay, but I had a technical problem here in Italy, but now everything is solved. It's a pleasure to talk about midlife migraine and what is the menopausal connection, because this has been a topic I have studied very much when I was the age of Professor Ornello, that was so brilliant to introduce the topic. Here my disclosure of interest. I would like to start by saying that for sure migraine is a female condition. And if you look at these famous curves that underline the fact that women more or less they suffer 3 times more than male subject from migraine during their fertile age, they don't suffer migraine so much when they go into the aging process. But this occurs following the age of 60, 65, probably because they start suffering from other brain condition. However, as you can see, the prevalence is very high when we are fertile, and this is related to the menstrual cycle and especially to menstrual migraine, but is also quite high around the time of perimenopause. And we see from this study that around the age of 50, there is a significant amount of the condition. There are many reasons why this is the case. So why migraine is a gender disorder? We know that influence of estrogen are crucial, and there are many different mechanisms. We don't have the time to go into all this story, but you recognize that on a background of a genetic disposition, we have plenty of mediators, both in the central nervous system and even in the uterus. They may affect the burden of the condition. Nowadays, we know, for example, that pro-inflammatory cytokines, prostaglandins, produced by the uterus at the time of menstruation can amplify the pain threshold into the brain. This is a premise that is very important to understand a certain point. And a last concept that is relevant, I think, and probably Raffaele already told you, but I want to remind you because it will help to understand what happened at the time of perimenopause, is the fact that we know since many, many years that migraine is strongly related, especially migraine with aura, we have already heard, with a high state of estrogenic condition. So, for example, a very good example is pregnancy, but we have seen also is the use of hormonal contraception, and therefore we may apply a certain kind of caution when we prescribe steroids to a woman also during the postmenopause. But it's also true the other way around, that migraine, especially without aura, is associated with estrogen withdrawal, exactly when what we see at the time of the menstrual window at the time of the pill break when we take combined hormonal contraception with a break of 7 or 4 days. But this is also true when, for example, we prescribe hormonal replacement therapy in which we have a break or we have a sequential of estrogen and progesterone, because we really have a change into the balance of the two hormones. You see that this is really true, and what we will analyze is the menopause period, but it's very important to follow the woman across the reproductive lifespan, because you have to believe me that they are really the women. They have more migraine during their life, especially when the onset is related to menstruation or the exacerbation is related to postpartum, and then in the fourth decade of life, women become more symptomatic. This is the category of women. They are at higher risk of having severe migraine in the perimenopause, and most importantly, they are the ones that go into chronification of the disorder and into a high use, for example, of painkillers. And this is a special category of women that is very difficult to handle, and neurologists and headache experts know this very, very well. Why this is the case, and why it's important that we have a dialogue with our colleague in the headache field? Because I don't know if you are aware that they usually classify the severity of migraine in women's life according also to the frequency. And imagine what is happening in the time in which we have a chaotic situation in terms of hormones. This is very common during puberty, but is even much more common during the perimenopause, because reproductive endocrinologists, they know this very well. We have a deficiency of progesterone, but most importantly, we may have up and down of estradiol plasma level. And in particular, subset of women, we may have extremely high level of estradiol followed by extremely low level. And this is known as the loop phenomenon, in which you may have a second rise in estradiol level during the mid-late luteal phase. You may have polymenorrhea, oligomenorrhea, heavy menstrual bleeding, abnormal menstrual bleeding, and this is real a time in which you have severe migraine, you have an increase in the frequency and the severity, but it's also very important to share this information with the headache expert, because if you take a diary of the menstrual cycle, you should consider that if you have a shorter cycle or heavy menstrual bleeding and prolonged bleeding, the characteristics of the rhythm intensity and of the menstruation will really affect also the days of headache in diaries and the attitude of the headache expert to, for example, prescribe a certain kind of prophylactic treatment or a certain subtype of painkiller. So really we need a dialogue. Why we need this dialogue? Because this is a study I like very much, because it was produced so many years ago by Anne McGregor, that is a very good friend of mine, and it's really one of the best experts ever in this field, in which she was so smart to do a study very simple, in which she said at what time women, they go to high specialized clinic in migraine. We know that the onset of migraine, it's really around the time of puberty or during the fertile age. But women, they usually cope with the condition. They go on, yes, they can consult the migraine clinic, but it's really following 40 years of age that women go into a high specialized center, because really they cannot stand anymore the condition and they want to do something more specific in respect to their condition. And therefore, pre and perimenopause is a time in which, if we have a patient with an increased frequency or an increased severity of migraine, we have to send to the specialist. But what happened at the time of menopause? This is a cross-sectional studies that was conducted in Taiwan on a quite big population, 1,500 women between the age of 40 and 54. And you see that apart showing a 1-year prevalence of migraine around 16.5, that it's a little bit lower in comparison, for example, to Europe, but they were smart enough to report this prevalence according to the different phase that we know very well in the menopause field. They are the stroke criteria. So they divided among premenopause, early perimenopause, late perimenopause, then separated natural menopause from surgical menopause. And it's extremely interesting to observe that it's really during the late perimenopause that there is a significantly higher prevalence of migraine that touch almost the double of premenopause, 31%. Interestingly enough, this data confirmed a study I will show you in a minute, that is one of my first study in the literature, that suggests that surgical menopausal women, they are significantly affected. We don't have so many explanations in the literature why this is the case, because look at how is striking the difference. Women, they are really postmenopause into a natural menopause. It's only 7% if they don't take any hormones. Whereas in surgical menopause, it's 1 out of 4 women, they are suffering from the condition. And there are some hypotheses out there. This is really because it's a sudden condition. These women, they may be enter menopause at the time in which they have this peak and lower level of estrogen because they have bleeding, they have hemorrhagia, they have fibroids, they have adenomyosis, and you know these women, they are so difficult to be treated with hormones, and this is the reason why they enter surgical menopause with hysterectomy or ovariectomy. We have data out there, as you know, suggesting there is a link between this condition and migraine during the fertile life. It can be emotional distress. It can be also androgenic deprivation. We really don't know very much, but it's absolutely true. And you see, this is in the history. This was a study published in Maturitas in 1993 from our group at that time, in which we really saw this, that women with natural menopause has an increase. In 2/3 of the cases, women with a history of migraine and they come to a menopause clinic, they improve. There is no change in a significant percentage of patients, and there is only a worsening in 9% of these women. And believe that these women in which you have the worsening of migraine, in absence of many treatment, already at that time we observe they were the one, they were more symptomatic, they had blood pressure, borderline blood pressure, etc., etc. And since then, we developed a lot of research on migraine. I will show you in a second. And you see, even at that time in which we were much more used to do surgical menopause in fertile women, because as you know very well now, we tend to do ovariectomy only after the menopause and not during the fertile age. We save the ovary if we can, of course, but you see the worsening in this patient that were already suffering was striking, 2/3 of them. In more recent years, the literature has investigated very much the linkage between perimenopause, vasomotor symptoms, as you know, in relation to having migraine. This is extremely interesting because we have heard from Raffaele that migraine is a risk factor for cerebrovascular and cardiovascular condition, but we know that also vasomotor symptoms, they are risk factors, and we know that from the seminal studies in the SWAM cohort, the study of women's health across the nation. This is a study I like very much because you see it considered the different stage of the menopause, perimenopause, early perimenopause, late perimenopause, and postmenopause, dividing women they have never suffered from a clinical relevant migraine, and women, they were migraine sufferers. And you see that especially in the late perimenopause, so that is a data that is extremely interesting for us, because these women, they are the one coming to our office asking for treatment, and we have to take the right decision, because we have heard that hormones, they are not so good friend of migraine from a cerebrovascular point of view in women with active disorder. And we have to be careful, because these women, they are requesting our help for severe hot flashes, night sweat, but we have to consider many characteristics of the migraine before prescribing. There is a shared pathway between migraine and what happened in terms of vasomotor symptoms during the menopausal transition. This is a nice cartoon that summarizes this story, in which you see that estrogen withdrawal is one of the factors initiating some change in terms of sympathetic tone, in terms of noradrenaline, and giving a sympathetic hypersensitivity. And this can be an explanation why these women with migraine, they may suffer more from frequent vasomotor symptoms. But there is also another explanation, that the same estrogen withdrawal in women during menopause, of course, we know that we will have an alteration of the thermoneutral zone, so we have a change in the thermal homeostasis, and we have a vasodilation. And this vasodilation may be strictly associated with sympathetic system. So at the end of the day, estrogen withdrawal, hypothalamic abnormalities, this norepinephrine autonomic influence, and some also potential vulnerability at the vascular endothelial level may be mechanism linking these increased vasomotor symptoms in migraines. So we have to study really more in depth this association. And why we have to study more in depth this association? Stephanie Fabian, she was smart enough last year to publish the study of this DREAMS study. This is a cross-sectional analysis of a data registry on experience of aging, menopause, and also sexuality. You see the number is extremely huge, more than 5,000, almost 6,000 were included in the analysis, 45, 60 years of age, and 1,300 and more report a migraine history in this sample. Women at the mean age that was typical, the immediately post-menopause age, 52.8. They were mostly white, and post-menopausal, 1 out of 2. It was extremely interesting to see in this adjusted analysis that women with migraine were significantly more likely to have a severe, very severe hot flashes. So not only the presence of migraine is higher in women with hot flashes, but is also the severity of hot flashes that is higher in women with migraine. And there was a confirmed association of migraine with a diagnosis of hypertension in adjusted analysis. So this large cross-sectional study confirms an association between migraine and vasomotor symptoms, an association with hypertension, providing a link with cardiovascular disease risk. And this is the reason why we really need to pay attention to women with migraine, because they are the one they can be much more vulnerable. So migraine is an additional red flag in our workout of the cardiovascular risk in postmenopausal women. And this is extremely recent, and is a paper that was published in Menopause just a few months ago. And it's very interesting. This is the CARDIA study, the coronary artery risk development in young adults. You see, almost 2,000 women They were studied during the transition. Probably you are aware that during the transition, there are different trajectories longitudinally of the vasomotor symptoms. There are some women, they have just minimal vasomotor symptoms. There are women, they have increasing vasomotor symptoms across the transition. And there are also women, they have persistent vasomotor symptoms, meaning that these symptoms, they start very early during the transition and they last long over time in women, even more than the average for 8 years. Women, they may suffer also longer following 60 years of age. In this study, what they examined whether migraine headache and VMS trajectory over 15 years of observation were associated with a high risk of cardiovascular events and stroke, both ischemic and hemorrhagic. And look at the results very briefly. Among women with minimal vasomotor symptoms, they were the majority, they were increasing vasomotor symptoms and persistent vasomotor symptoms. Over 15 years of observation, there were 81 incident cardiovascular events, including 42 strokes. And very importantly, women with history of migraine and persistent vasomotor symptoms had a greater risk of cardiovascular disease after adjustment for age, race, estrogen use, oophorectomy, hysterectomy, compared with women without migraine histories and with minimal or increasing vasomotor symptoms. The association was attenuated, when the data were adjusted for cardiovascular risk, but it was still there. And therefore, again, it's important to study the trajectory of vasomotor symptoms in these women, but as you can understand, it's very relevant to end vasomotor symptoms because these are two concomitant conditions. But since we know very well that vasomotor symptoms, they may give those signs, for example, in the white substance, exactly as Raffaele showed in terms of migraine risk and vascular insult in the brain, we really need to find a therapeutic solution to lower the intensity and the frequency of vasomotor symptoms to protect the brain. And this is the reason why we should include into this cartoon we published with my dear friend Tommaso Simoncini and Peter Cigrau that vasomotor symptoms, persistent or moderate severe, especially if they are associated with migraine, they are concomitant to this higher cardiometabolic risk, and therefore we have to consider this in our daily life. The second part of my talk is devoted to how we handle from a therapeutic point of view this patient. We are lucky enough that we will have in the future, and in some countries we already have some specific drug for vasomotor symptoms, the fezolinetant and elinzanetant, so the NK3 antagonist. And probably this may be drug that will help the brain to relieve hot flashes and without adding any risk to women with migraine, because we know that hormones, they may have a risk, but hormones, they are still a pillar of menopause treatment. And we have to consider that we have a very old data suggesting that when you stabilize the hormonal fluctuation across the menopausal transition, you may significantly improve the clinical pattern of the condition. You see, this is a study that was published so many years ago. They are retrospective data, but they include both peri and postmenopausal women, in which you see that M. McGregor show very clearly that when you treat with estrogen, especially if you treat with a transdermal route of administration, and keep in mind the peculiarity of the transdermal route in terms of liver induction of protein and factors, they may have a procoagulant. Imagine when you use conjugated estrogens, we have to be careful because we have an increase in sex hormone binding globulin, in many proagulant factors. But at that time, you know, before the WHI, that was very modern to compare conjugated equine estrogen with transdermal estradiol. And you see that especially transdermal estradiol give an improvement. And keep in mind that this is the #1 treatment for women with migraine, both because you will see that there is a clinical benefit by using transdermal estradiol in comparison to the oral route, especially conjugated equine estrogen, but also because of the cardiometabolic risk. And in this case, you see that was a cyclic association of progestins because we were across the transition and we really need to stabilize the bleeding. There is, however, a worsening in some patients, especially with the oral route of administration. And this is true, and this has been described also in large population study. This is a study that was conducted in Norway, and they have a very beautiful registry in northern country to describe, as you know very well, the association between migraine with hormones. So we have also this registry for hormonal contraception, but we have it for HRT as well. And you see that especially migraine, but also the other form, the so-called tension type headache, they are a little bit associated with the use of hormonal replacement therapy. So we have to consider that hormone play a role, and we really need to be careful. This is the reason why we really need to customize and individualize the treatment in those women that have a high level of distress associated with the menopause. Because on one hand, we have to treat the vasomotor symptoms, but on the other way, we really need to avoid a migraine worsening. The same data are present also in North America. This is an analysis of the women's health study. And you see that in a significant number of postmenopausal women, more than 15,000, migraine was present in 11% of these women postmenopausal. But women with migraine, you see, were significantly younger at a younger age at menopause. This is also important because there are some data, not so many, because as you know, it's a rare condition, but suggesting that premature menopause is not a benefit for migraine patient, you know, but can be a worsening of the condition. Again, confirmatory data that surgical menopause is associated with a burden, a higher burden of the condition, but these women with migraine were more likely to be current users of hormone therapy. And that was true after adjusting for several variables. For current users, compared to never users, is more or less 1.4. So absolutely superimposable to the data in northern country in Europe. And interestingly, in this data, the odds ratio were similar for users of estrogen alone and users of both estrogen and progestins. And this suggests that probably estrogen, they play a role much more than progestogen. With this in mind, several years ago, we studied a little bit which one is the best regimen for women with migraine during the postmenopause. And therefore, we consider different categories of menopause hormone therapy combination: continuous sequential, in which we induce the bleeding; continuous combined, in which we avoid the bleeding; continuous sequential, in which we may compare transdermal route with the oral route; and even the cyclic sequential, because we know very well, as I told you at the beginning, that the 7-day interval is a trigger for perimenstrual migraine in some women. And it was important that before the WHI, we were prescribing much more hormone replacement therapy in Italy, and we had a significant amount of patients with migraine to try to study this. And also a drug that in Latin America and Central America, in many countries in the world that we know so well, that is Chibolon, that is a selective STIR, a selective tissue modulator of the estrogen receptor. Unfortunately, Tibolone is not in North America. So, but it's in our hands, and it can be a useful treatment to relieve hot flashes and to prevent osteoporosis, exactly like all the other hormone replacement therapy. And it was widely used at that time in my country in postmenopausal women. So we have accumulated some kind of clinical experience on this different regimen. And you see that we published in Maturitas so many years ago very interesting data that by using the same progestogen, that at that time was the medroxyprogesterone acetate, we use much less now following the WHI, but in any case, even with a progestogen that we may define that the worst progestogen, as always in terms of vascular activity, you see that when you use transdermal prospectively, both in terms of frequency, both in terms of days with migraine, it's true that with conjugated equine estrogen, you significantly worsen the condition. Whereas there is no impact of the transdermal route of administration. So we didn't see so much of an amelioration. Remember that McGregor data, they were retrospective. We saw stable situation. So this is very important because many women, they are afraid that hormones, they may worsen their condition, but with transdermal, this is not the case. And also, it was interesting also to observe that severity of the condition, and most importantly, the number of analgesics, because remember that the number of analgesics is a surrogate indicators of severity of the condition, impairment of daily life in this patient, was really stable over the months. And so this is very important to remember in clinical practice. But we also compare 3 different oral administration, and you see that with the 3 of them, there was a significantly increase in the frequency of migraine attack. But the higher increase, and so we really need to avoid this, exactly like in the fertile life, even in postmenopausal women, we have to avoid the free interval, because with estradiol valerate 2 milligram and CPA acetate 1 milligram that we have in Europe, I don't know in which other countries you have this treatment, we were able to observe a significant increase in the frequency exactly with the sequential use of conjugated equine estrogen and medroxyprogesterone acetate. Whereas when we used a low dose, 1 milligram estradiol and meta 0.5 continuous combined, there was only a little increase, but much more less. So you will understand very easily why my key message will be, please avoid the bleeding during postmenopause, and even if you can during perimenopause, in order to avoid this fluctuation in the estrogen. Indeed, you see it's the same for the days with migraine, and it's the same with analgesic consumption. And the last piece of information that I think it's interesting for the audience, because these data were produced following WHI with the use of Tibolone against the best combination, so estradiol plus nita. In women, they were coming to our clinic with many in women with a very high severe condition, so the one that we consider at risk of overuse of analgesics. And you see that we recruited this patient. They were highly symptomatic in terms of hot flashes and pain, migraine pain, also tension type headache. So this mixture of combination of severe headache, so more than 15 days a month of this chronic migraine, and that is a real mixture between a migraine and tension type headache. We can comment with Raffaele in the discussion. And you see that with Tibolone, we did not observe any worsening of the condition in comparison to the combination of estrogen and progestogen. And we even observe a significant reduction in the number of hours of severity, but this was really related to a better responsivity to the analgesics. So at the end of the day, In these women, if you don't have other side effects, you can use tibolone and you can help them to decrease the number of analgesics and the number of hours suffering with pain. And I want to finish my talk with this cartoon that is very nice, produced by Anne McGregor, in which she summarizes whatever she knows on this topic. And she really considered our data very much, suggesting that in non-hysterectomized postmenopausal and perimenopausal women, it's better to use the lower estrogen dose, the transdermal dose. And she also introduced a new concept. I didn't show in a slide because there are only few anecdotal data on the combination with levonorgestrel intrauterine system. So putting levonorgestrel directly into the uterus and using transdermal estrogen can be also a very good way to administer progestogen, and also using natural micronized progesterone or dydrogesterone, I may add, because it's completely similar, can be anecdotically, we don't have a formal double-blind controlled trial or observational study, but in clinical case and in our practice, this is very useful. And as you can see in this cartoon that was produced before the introduction on the market of NK3 antagonist, she proposed also SNRI, because neurologists and headache experts, they know very well that you can catch two birds with one stone. You may improve the mood of vulnerability that is very typical in migraine patient, but you may lower also vasomotor symptom. You can even use alpha-adrenergic agonist clonidine. We don't use so much anymore. And very importantly, also lifestyle measures are crucial for this patient suffering from both vasomotor symptom and migraine. Cognitive behavioral therapy, exercise and weight loss. There are many data out there. And I would like to finish with a cartoon that was produced by Raffaele, because I like this cartoon very much. He was able to summarize in a very interesting review article whatever I have told you in these 30 minutes, the pattern of migraine in postmenopausal women. In some, you have an amelioration. In other, you have a high burden of menopause symptom and a high burden of the condition of a migraine. You use a lot of analgesics, you go to see the headache expert, and we really need to try to avoid the fluctuation. We really need to use a continuous regimen, and we have to try to use natural estrogen. And he's always proposing also non-estrogen compounds, because as being a neurologist, being a migraine expert, of course, is very familiar with psychoactive agent, whereas gynecologists, they are less familiar. And this is really my summary. And I'd like to thank you very much for your attention, and you are still on time to register for our World Congress in Melbourne. Thank you very much for your attention. I'm ready to take the question.
Many thanks, Rossella. Many thanks, Professor Nappi. Let's go directly to the questions. We have, I see several questions in the chat, and also they have come to me. And for example, I have one here for Professor Ornello. Are there preventive drugs or measures to control the increased vascular risk of women with migraine, particularly during the menopause? So, in summary, I suppose the person that raised the question is asking that since it is a risk associated with migraine, do we have any preventive drug or some preventive drugs which might be of special interest during the menopause?
Well, this is a very interesting question, because it's a question, it's a clinical question, even not only in the menopause clinics, but also in headache clinics, and it is frequently asked by patients also. As we have seen in the presentation, the mechanism of ischemic stroke and of other vascular disease in women with migraine are very complex, and there are even some hidden factors. So at the moment, we don't have any preventive that can any preventive drugs that can decrease the vascular risk that is specific to migraine. There are some interesting animal studies that showed that the use of preventive drugs for migraine could decrease the effect of cortical spreading depression, that electrical phenomenon. And so I would say that keeping migraine low as a tax can contribute to decrease the vascular risk of migraine, but this is speculative. There are also some clinicians that use aspirin to prevent migraines and to control vascular risk, but this is a very debated question, and there is no clear evidence about that. So I don't feel to recommend this in all women in perimenopause because it has a very poor rationale. The best thing we can do is to advise a lifestyle that is as healthy as possible, because a healthy lifestyle can contribute to decrease not only the burden of migraine, but also the vascular risk, and keep them at a minimum. So it's more like a non-pharmacological point of view than a pharmacological one. We don't have drugs, but we have a device, and it is very effective.
Okay, thank you. Now we have here two questions which are close to each other for Professor Nappi. One is, how was the choice, the dose of hormonal contraceptives against migraine? And there is another which I think is similar or related, at least, is contraception with natural estrogen may be more or better indicated in women with migraine during the transition. Rossella.
This is a very good point, and we wrote a review together with Raffaele and Simona Sacco and Professor Tassorelli here in Pavia on this topic. And there was also a debate, a clinical opinion in the New England Journal of Medicine about this. So it's a very important question, but we don't have an answer. And one of the reasons why we propose also this webinar in the IMS education is really because we want to increase our ability to go hands in hands as headache expert and reproductive expert or gynecologist overall, or primary care physician dealing with menopause every day. Why is this? Because we really need to do studies together. Because looking at the literature and what we know, it's true what you are saying, that natural estradiol containing pill, we have now 2 containing pill with estradiol. In some countries, we have even estritrol. And you have the data out there suggesting that the impact in terms of coagulation, in terms of blood pressure, in terms of lipid profile is significantly lower. And therefore, in women, they really need to go throughout the menopause transition to control the bleeding. And they are in need also of estrogen, because I know that neurologists, they always say, you should give a progestogen-only pill. Yeah, I know, I published that. But there are some women that cannot be okay with a progestogen-only pill. Remember also, during the fertile life, there are some women, they need to treat the condition, and you do not relieve very well PCOS or other situation by using POP. And therefore, combining natural estrogen can be a solution, and we don't have to fear so much, especially migraine without aura, but also in women with a history of migraine aura that do not worse, with a good lifestyle, with a nice follow-up. In some selected cases, we may use, because this is a very crucial point, the use of low-dose estrogen in women that are higher risk of cardiovascular health. And we have to study more. At the present moment, the suggestion is try to lower the dose. And if you look at the toolkit that Susan Davis published, and you can find it at the IMS website for free, you see that she was smart enough to suggest you may use a POP pill with risperidone, for example, combining with very low dose of transdermal estrogens in order to try to balance the cycle, to balance this erratic ovarian activity, and to improve menopausal symptomatology. So these are just anecdotal data, but we really need to produce more formal data to try to give real advice to clinicians. Do not fear too much the cardiocerebrovascular risk in some category of women at low cardiometabolic risk in which we may use it.
Thank you. There is another question which I think you are the candidate to respond, which is related with what you just commented. I don't know if I am interpreting correctly. The reading is, what about the risk with utrogest? I suppose it's utrogestan probably. But it writes in continuation, not progestins, but bioidentical. Probably they are speaking of milder progesterone.
My dear friend, remember that micronized progesterone is a bioidentical progestogen. And unfortunately, my dear friends, when you prescribe bioidentical hormones, they are not compound, so and not studied in randomized double-blind clinical trial, you are out from the good practice we suggest as International Menopause Society, and as I know, the Menopause Society and the European Menopause Society. The use of natural estradiol and natural micronized progesterone is now what we suggest as a guideline overall to lower the cardiometabolic risk, as you know very, very well. They are very nice review. Of course, we don't have a formal study, as I told you, in migraine patient, because as you know, we are prescribing not so much hormone. Following the WHI, we were very much scared. Neurologists, they always are against hormones, but of course, because they see a lot of cases of ischemic stroke. I saw before the summer break a woman 21 with a hemorrhagic stroke, and believe me, when you prescribe to a young lady a pill and then you see her in emergency, it could be your daughter, you are very scared. And of course, we see only one a year, but neurologists and experts, they see a lot. And as you know, sometimes you cannot predict the risk, and therefore we really need to prescribe the lower effective dose. We really need to avoid as much as possible the risk, and prescribing natural hormones is the key. But we really need to produce a consensus. I propose to Professor Raffaele Ornello and all the big guys in the migraine field to produce consensus documents in order to stimulate the research on this topic.
Thank you. I should say that we have so many questions here that we will not be able, because I have been told that I should stick to the time. So we are already passing the time, but I think we will have time for 3-4 more questions. Please be brief in answering. This is for Professor Ornello from Dr. Emerix. Is there a link between migraine and vascular dementia? Seeing the link with microembolism? Very interesting.
Yes, this is an interesting question that is difficult to answer, because migraine is typical of young women. So to assess the development of dementia, you would have to design large studies and follow them for decades before detecting a significant risk of vascular dementia. But nevertheless, some groups ventured the idea of assessing this kind of risk, and the data are still conflicting, but most studies actually found an increased risk, a slightly increased risk of vascular dementia. associated with migraine, especially with migraine with aura, and this could be due to microembolism, but this is still to be confirmed, and it is difficult to confirm it because we would need a large amount of data.
Okay, and the second is also for you. The next one is from Dr. Kata. A large percentage of women with fibromuscular dysplasia of the carotid arteries have migraine. These women are also at higher risk of a stroke. I wonder in the studies associating migraine and stroke, whether undiagnosed fibromuscular dysplasia could be a factor.
Yes, it might be, but we should think that fibromuscular dysplasia is a rare disease, while migraine and vascular diseases are both frequent in the population. So this might explain the undetected or subtle or subclinical manifestations of muscular mass formations could explain part of the risk, but not all of the risk.
Now for you, Professor Nappi, excellent on estrogen and vascular. As a biochemist studying hormones and mood, we have found it makes a big difference when women use enough real progesterone, not progestins, to get calm along with enough estradiol. By the way, we have found the key is that progesterone is bioidentical, that enough is used, form is personal preference. We have found transdermal very effective for women to get calm and for endometrial protection when enough is used. Your thoughts? Probably it's a summary of Rossella, of what's...
No, I'm not sure I understood correctly. I mean, me too. I was using a lot of a combined patch in which I had transdermal estradiol and the only transdermal progestogen that can be absorbed by the skin. Because remember that progesterone is not enough absorbed to protect the endometrium. I'm not aware of published data in regular literature in which you may say that by using transdermal progesterone cream, you can protect for sure the endometrium. Therefore, I use a lot of micronized progestogen. I use orally at bedtime, and this is very good, in my opinion, to also improve sleep. That is another factor that is so relevant for mood, behavior, cardiovascular health, and also hot flashes. Or I use a lot also intravaginally to better control the endometrial growth. This transdermal combined patch is not available all over the country, all over the world. We don't have a really very good data in this category of patient. But when you stabilize the hormone and you balance very well estrogen and progestogen in the brain and into the circulation, and you do not induce so much liver protein, you are doing something good for migraine patient. And therefore, if you have it, why not use it?
Okay, another question for you. Relationship between migraine and depression in postmenopause from Dr. Paredes.
We have data, and I think Raffaele can answer better than me, that suggests that there is a relationship between depression, but also anxiety and other mood disorder in general with migraine. The data we have in the literature suggests that these women, the one having mood disorder, the one having sleeping disorder, they may have not so high improvement in migraine. But if this is mediated by a common milieu, a common vulnerability in terms of neurotransmitters, etc., or if it's just related to the fact that we know that if you are deprived of sleep, then the morning after you will have a sort of hangover, and therefore you will feel really anxious or maybe not in control of the reality, and then you will develop depression, etc. So it's really a so-called domino effect that this situation that goes hands in hands. I know that Stephanie Fabian in the study I show you, she is publishing same data on sleep, but the association is not so strong, and she's publishing some data of mood, because when you correct for different factors, it's very difficult, because migraine is a multifactorial disease. And this is the real true also for vasomotor and all the other symptoms. Not every woman is the same as another, and it's very difficult to control for all the factor. And, you know.
Okay. Then there are actually two comments. One is an excellent informative webinar. Thank you. Thank you. And another one, Professor Nappi, could you please shoot your last slide again? Thanks. I should say that the webinar will be available in the website of the IMS, so you will have all the time to repeat it again, as many times as you like. Then, from Dr. Law, is there any correlation with histamine intolerance and migraines for you, Raffaele? Correlation between histamine intolerance and migraines?
Yes, there are some. It used to be a large stream of research in around the 70s and the 80s. So there are many.
I remember, you don't remember because you're too young.
Yeah, there are many. I probably started working after this when this stream of research was about to give way to other streams of research. And I am not a pharmacologist myself, so I could say something. But this correlation was found. And there is no recent evidence about this. Maybe we could start studying that again now that we are in the age of CGRP, this kind of vasomotor peptide that has been told to be one of the main aspects of the main promoter of migraine pain, and it's also one of the main promoters of vasomotor symptoms in general. So we should try and pick up histamine from research from some decades ago and put it again on the stage. So thank you for this question.
Yeah, we can rejuvenate this research. I remember a paper I read so many years ago, and there are some patients, for example, they have much more allergies, cutaneous rash, and and they have migraine, you know, and there is a correlation between this condition. So it was a stimulus in the 70s.
Yes, especially for perimenopausal symptoms that's correlated to histamine, but not also to that. And I think that much of research about CGRP performed in recent years converges with that on histamine.
Okay, two nice questions. Again, all are very nice. This is from Dr. Yadav. Is there any data for you, Professor Nappi? Is there any data on ethnic differences in migraine prevalence during the menopause transition? Interesting. Ethnic differences.
You know, I don't think that the Swan study published this data, because, as you know, the only way to see really ethnic difference in the transition is really to follow the women from premenopause to postmenopause, because I'm sure we have some ethnic difference, Raffaele. I'm not aware in general how is migraine following the age of 50 in different part of the world. Maybe you know better than me. But if you ask me in correlation with the transition, I'm not aware of this data. They were not analyzed. For example, there was analyzed the sexuality, it was analyzed the vasomotor symptoms, but not the migraine incident. And they are starting now, you know, because there is this correlation with vasomotor symptoms. So maybe they will have a look, because if you think about that persistent vasomotor symptoms, they are much more frequent. For example, in African Black in the United States, we may assume that having more hot flashes, these women, they may have even more migraine, but we're not sure about that.
Okay, now Well, this one I think has been. Are there any studies to show the relationship between migraines, progesterone, utrogestan, and migraines? I have seen women with severe migraine attacks when taking utrogestan, even when given vaginally, unlicensed use, but common practice in the UK.
With you. I was revising the literature to do another seminary on migraine on Friday, and there is a very recent paper suggesting that the use of progestogen may modulate the pain threshold at the central nervous system, especially in those nuclei, in those areas in which they are so relevant for the migraine pathogenesis. But you know what is out there, and the progestogen has not been so well studied. And also remember that when you prescribe a progestogen, you modulate the amount of estrogen and the activity of estrogen. And so it's possible that even when you use progestogen alone, you change the sensitivity at the level of the receptor, at the level of the neurotransmitters, at many different levels, at intracellular levels, the activity of the estrogen signal, you know? And so to be able really to demonstrate that it's a pure progestogen effect is not so easy because every woman, even a woman she is postmenopausal, she has still there some estrogenic signal. There are women, I have patients, they have a periodicity of their migraine even during postmenopause. There is 1, 2, 3 days in which migraine occur, even though the bleeding is not there anymore. So what this means, that probably the hypothalamus is still sensitive to some oscillation into the brain that may be related to some sensitivity that is left in there to a small amount of hormones we have in our body.
Okay, there is now a question from Professor Shalin Janti. Could and would not postmenopausal women with non-aura novel onset severe migraine provoked by neck pain stress benefit from simple beta blocker, bisoprolol, to protect heart and vasculature heart rate? Raffaele.
Yes, beta blockers are not specific to this age group. I would say that they're much used in adolescents or in young adults. So beta blockers are good migraine preventers at any age, almost any age, unless they have contraindications. But I would say that in this age, combining this kind of pharmacological interventions with non-pharmacological interventions, such as exercise, physical therapy, just to keep the health of the muscles and of the neck and spine, can contribute to a significant increase in quality of life. It's a particular age for women, the perimenopausal one, even generally for health conditions. So my opinion is that we should treat migraine as we treat it in other ages, but for non-pharmacological therapies, we can do more.
Okay, thank you. And the last one, we have some more questions, but sure, we are not allowed to stay more. So for you, Professor Nappi, Botox for migraines in menopause, what do you think?
I think it's better Raffaele answer because I don't have any experience specifically of Botox or migraine. I always send my patient to the neurologist. There are not so many, they are candidated to Botox. So I cannot generalize. I will say something that is irrelevant.
Raffaele, would you like to say something?
I think the same that I think for beta blockers, the Botox is an excellent drug to prevent chronic migraine. So migraine occurring on more than 15 days per month, but at any ages, it's particularly favorable for for women in post-menopause, but because of a matter of age, because other preventives for migraine have more effects on the body, while Botox is just local. But I think that it's a preventive treatment like another.
Okay, many thanks. I think we have from BT Congress, 2 free slides. Could you please pass them? And yes, this is just the advantages of being a member of this society, the access to climateric, many educational activities, the participation in congresses, and so on. The next one, please. Again, exclusive offers for members, free 1 year IMS membership. This is important with completion of IMPART level 1. IMS membership offers in partnership with local regional societies who are members of CAMS, and monthly live events as the current one. And I think there is another one, the last one. Yes, this is our Congress on menopause in 1 month in Melbourne. So you are all invited. It's time to thank you, all of you, for attending. Our speakers, our dear speakers, they are so good. It's a pleasure to be there, to be here. We could stay for longer, but we are not allowed. So many thanks again for your talks.
Antonio, thank you, Raffaele. See you soon.
You.
Ciao, ciao.
Bye bye.
You.
Thank
Bye.
you.
Ciao.